move on now to Dr. Maxwell, and I understand that there were two reasons that Matt was delayed, and their names are Avery and Eden. and Matt, among other things, today is
single father.
Is a single father.
I know.
And Matt is a cardiac surgeon. He is the chief of cardiovascular surgery at IHI, and he is also the CEO of the IHI Foundation. And he's a terrific guy, and I love working with him. And he's a great surgeon, and he'll give a great talk. And we welcome.
Thank you, Stan. So because of all those things, I get to wear jeans, and I appreciate it, Stan. You know, it's interesting. I was listening. I tell you what happened is that my wife, Marion, whom a lot of you know, is going to, she has a very hard job, and so they had this work-related thing. She was telling me it was going to be very difficult, and would I be supportive, you know, modern husband and everything. I said, sure, honey, what is it? She says, well, I have to go to Hawaii in February. Would you mind keeping the kids? I said, sure, honey, that's all right. Anyway, and so this morning, I'm supposed to give a talk, and this morning I've got it all wired in. You know, we drop her off. We're up at 5:30, Avery and Eden and I, and we drop her off at the airport, and I run back home to get ready to come give this talk, and at 7:45, because the sitter's due at 8:15, I get the call from the sitter, I can't make it. Aha. I said, oh, that's fine, don't worry, I hope everything's okay in your life. I just found out what my problem is. I was listening to Stuart Longstock. Stuart just joined us from Emory. You heard his a little bit of an accent. I think he's from Glasgow, Montana, but he spent a lot of time in Atlanta, and he's been a terrific addition, and we've learned a lot from him. We always learn something when we had new people, and Stuart's new, and he taught me this morning as I was listening to his thing that I heard all this about depression. I recognized that I must have just had heart surgery because I was pretty depressed this morning. I'm supposed to talk about, I'm on the list to talk about heart valve surgery, and I'm going to talk to you for about 5.5 seconds about it because I've changed my mind about what I want to talk about. And it's kind of ironic because you know, we specialize in the treatment of disease states. But what our hearts and minds are around and what our souls are about is the creation or enhancement of health. And we have so much in our lives that we do that we can change to avoid a potential collision with disease, that I want to talk a little bit about that, because while most of our efforts and refinements in our practices deal with risk and benefit, deal with the technical aspects of repairing disease or treating disease, we really do like to talk about prevention, how we might live better in general. Heart valve surgery continues to be the mainstay of what surgery is about, what we really are interested in, what most of our efforts are toward. Heart bypass surgery is about 45 or 50% of it, and about half of it's heart valves. But this program, as many of you know, and was founded, at least the foundation part, the clinical practice, the melding of cardiologists and cardiac surgeons, was in large part founded by Carlos Duran from the surgery side and Stan Wilson from the cardiology side, and it was Carlos Duran's interest and expertise with valves that what really gelled thought about surgery. And valves are pretty simple things, very, very simple. Good morning. Good to see you. I got a follow-up on you that you're doing some better. The machine quit going off, and my neighbor, victim, another guy. I went over to your place early this morning to drop the kids off, but maybe you weren't there. Yeah. Anyway, heart valves are a living entity, and there is nothing that that functions as well as your own native heart valve if it's develops. Eden, Avery, Beth, keep those girls quiet. Nothing works as well as those valves designed and developed appropriately by God. And when they malfunction or when they are affected by disease or infection, in the old days rheumatic fever was common, then we have to do something to either repair or replace them. Replacement or repair, if possible, to use your own living tissues in a way that restores valve function is preferable to replacement. And replacement is preferable to a diseased native valve in almost all states if you can't repair them. And the mitral, tricuspid, pulmonary, and aortic valves are the four named valves in the heart. And we repair tricuspids and mitrals as a regular part of our routine, and we feel like we've worked to refine that and continue to refine that and owe much of our success to Dr. Duran. The replacements in the aortic valve are more common, pulmonary valve is less common, and the replacement alternatives are tissue valves, and they're either human tissue valves, cadaver valves, for which we appreciate the kind donation of the previous hosts, the owners of those valves, who those valves are donated posthumously. So if you're not an organ donor, think about it. And then there are pig and cow valves, and soon to be an equine or horse tissue valve coming out, and those have to go through trials. They all have a profile of performance, of durability that changes depending on your age and your gender and the age of implant. They have different flow characteristics, and all those things are quite important. And valve surgery in general is a little riskier than bypass surgery, but it has all of the elements of recovery that Dr. Long spoke about, and all of the restraints and constraints of mechanical or engineered valves inside the human body. We're grateful to some heart valve companies that have helped to support or underwrite the cost of this informational gathering. And I see representatives from those companies, St. Jude, ATS, Medtronic, Edwards, are names of some companies that build these valves and have to go through rigorous testing. And I will say that it's a complex process to make choices and that fit a person's needs. But nonetheless, it's an important event in a person's life, and there's lots to talk about, but I've elected not to talk much more than that. Any questions about that? Sweet. Because of the time of year and because I have two daughters and am delighted by them, and my household is dominated by women, and it's kind of been the year of the woman for the last 20 or 30 centuries. What are you right? Somebody yeah. That we talk a little bit about prevention. All of the things that we're about to talk about apply equally to men in general, but specifically, we'll talk a little bit about women. And you know, all of us have had these sort of thoughts. I added that little thing down there when I took somebody to Hawaii this morning. That deal that hindsight is always 20/20 is true, I suppose. And the notion isn't really that we never knew. You know, it's the joke that we didn't ever know. All of us know, and I guess all of us think that we'll probably get away with it. We don't necessarily. We know that some people get away with a series of bad habits. Some people get away with murder. Most of us, however, have the laws of physics and gravity that apply to us. I sort of laugh because this week a patient who had been referred down who referred to me for an operation and sort of didn't really know me and got to know me by the brochure. And the first thing she says was, "You're older and fatter than your picture in the brochure." or words to that effect. That's what I heard. She might have said, "Gee, you don't really look like your picture anymore." And I thought to myself, I could A, lose weight, B, dye my hair, grow more hair, or just change the darn picture. And I'm probably going to do none of those things for a while. Most of us know the risk factors. Most of us know what we ought to do. Most of us know what our mothers and fathers or brothers and sisters or cousins died of or suffered from. My own mother has emphysema. And she won't go to the doctor, she won't listen to her son, the doctor, and she won't quit smoking. It's one of the most painful things that a person can do, a son, especially a heart surgeon, can do. And, it's not like she doesn't know better. It's not like any of us don't know better. It's a matter of choices that we make that seem to be very, very difficult at a time. And yet, 40 or 50 years ago, I got a picture of my mother from about 35 years ago, standing on the top of Half Dome in Yosemite with my brother that hiked up to Half Dome, and now she can't walk across the street to visit a neighbor who's been there for 55 years with him, and she still smokes. So it's not as though that decision's easy for her now. It's hard. But that decision made 50 years ago would have changed the last 30 years in immeasurable ways. It is not too late to make decisions in our lives that will change and benefit the last part of our lives. My grandfather, when he was dying of lung cancer at age 82, said, "I never wanted to live to be 83 until I turned 82. And I'm going to miss it." And he did. He died at age 82. But, in that dying observation, there's nothing that everybody in this room doesn't know. We've made all of those observations. Sometimes our patients make them for us. "Gee, you're fatter than your picture." So it's more than just our LDL and now HDLCs and ICAMs and ECAMs and ligand molecules. It's about quality of life. We talk to patients, and as Stuart said, it's the riskiest thing they're ever going to do. And we have this sort of disconnect where it's okay to have heart surgery in a crisis, and we boil it down to the risks, the one-time risk of heart surgery and recovery, and then after 3 or 6 months you'll feel restored a little bit and don't go back to your old health. And yet we don't measure the quality of life that could be quite a bit different than we could dream. Then leaf subsides to leaf, and so Eden sank to grief, so dawn goes down today, and nothing gold can stay, unless, of course, and this is the apology, you have a plan. All of us are born, and all of us will die, and that's a fact. Some will die earlier, and some will die later, and some will have lives that they will look back and say, that was a life worth living, and some will have lives of misery. And as Shakespeare said, there are tides in the lives of men that when taken at the ebb, or taken at the flood, lead on to great things. And we have those opportunities every day to make choices, to make smart choices, to remedy old, previous poor choices. That true repentance is change. We know that really to make change, one has to make different choices and follow through on them. So you got to have a plan. There are so many things we hear about day by day. These pleas about breast surgery and breast cancer is the most common one. It's no less important than what's made out to be, but the magnitude of the threat is something different than most people think. Amazing statistic. Statistically, you're sitting in this room, you're a woman, your largest chance, the thing that's going to end your life, potentially prematurely, is heart disease. And this is the piece that we want to get to. That most of coronary disease, and not valve disease necessarily, although there are some preventive measures of valve disease, but most of coronary disease is completely avoidable. And for those people who are programmed genetically to get coronary disease, unfortunately, by a poor choice of parents or genetics, you can delay the onset of the disease. You can minimize its ultimate impact by following the same rules. You know, you don't have to burn out early. You just don't have to. There are some gender differences. There are some race differences. Race is not one that we think about too much in Montana, although our Native American population, the first Montanans, are ravaged by cardiovascular disease. And even in populations such as that, it is largely avoidable. All women are at risk. The average age of onset, or at least the average age of the first heart attack and entry into revascularization, is about age 62 for men and 67 to 68 for women. That's an average, and it's a rule of thumb. Good morning. Nice to see you. And for that reason, somehow we think it's less prevalent, because it doesn't affect younger women as much as it affects younger men. But when it does affect them, it affects them in a powerfully different way than men. And the 1-year mortality risk for a woman, if you're a woman and you have your first heart attack, the chance of you dying in the first year is almost twice that as it is for men. Cardiovascular mortality is avoidable. And more importantly to me, that second bullet point, that's avoidable as well. The 10 or 15 years of prodrome, of limited life quality that ends up in this heart attack, that ends up in a 40% mortality a year later. If you get that heart attack, life is a little bit difficult. Life got tougher. What did John Wayne say? John Wayne said, life is tough. It's tougher if you're stupid. I can tell you stories from my youth that proves that. It's not as though stupidity drives us to make bad choices. Sometimes lack of information, which is what this is designed around. And sometimes it's this sense that, these things don't apply to me. They apply to all of us. Women are not protected from cardiovascular disease, which is an important thing to understand. Estrogens do seem to help delay the onset of the first heart attack, but if you have a heart attack, the estrogens seem to play a role in promoting the mortality. Estrogen replacement therapy, by the way, doesn't seem to impart a big benefit in cardiovascular risk. I'm going to avoid that. This is the longest longitudinal study ever undertaken in the United States, and we continue to harvest data from Framingham, Massachusetts. It is the birthplace of longitudinal population-based studies, especially for cardiovascular disease, and it has yielded a lot of important data. By now it's 37 years, and there are things that we know about women in particular. They tend to have less typical presentation. Only 45% have angina. Over half the time their heart attacks are misdiagnosed, as opposed to 30% for the men. There's a disproportionate relative risk increase for smoking, and a 1-year mortality that we talked about is quite a bit higher. There's something in women that doesn't appear in young women that doesn't appear so much in young men, and that's called the social smoker. Ever heard of that? I only smoke when I drink. I dated a girl one time. We were in really date. Don't tell your mother. Her name was Kathleen, and she was a Seventh-day Adventist, and she said, I only smoke when I drink beer. And I said, Kathleen, you're not an Adventist, you're a vegetarian. You know, a social smoker is a smoker, and most people who are social smokers would go on to have the same nicotine risks, because social smoker is more of a convention than a rule, and smoking in women is more deadly than it is in men. That's like the most unusual picture I've ever seen. I had to fit it in a slide somehow. It is that myocardial infarction presents in unusual ways. The symptoms of a heart attack may be subtle or ignored. And the danger may be underappreciated. Sylvia Plath wrote this poem. This is an excerpt from that about committing suicide. She wrote the story, The Bell Jar, about her failed attempt at suicide. And her preoccupation with that would end up in her early death. I don't mean to over-dramatize the role of cardiovascular disease in a person's life, but it's totally predictable that it doesn't have a very good outcome for those of us who don't make changes. "25% of women report taking care of a few things prior to getting medical care for an infarct, like feeding the family or finishing their shift." And I want to tell you about a woman. I've looked around, I don't see her here, but she presented to the hospital this way some 4 years ago. She woke up in the morning and felt sick, real sick. But she had to get her kids and her husband off to work and school respectively. So she made all the lunch, she made breakfast, made all the kids' lunches, packed her husband's lunch, dropped the kids off at school, went back to do some shopping at the supermarket, and felt like she was anxious to have an anxiety attack. So she took a Xanax. I won't, editorial comment I'll hold off on. She's driving a car on the road, by the way, that I share, so I'm a little bit worried about that. She goes and does her shopping, still feels badly, can't breathe, feels palpitations, goes back out, sits in her minivan, has another Xanax. Goes and takes her husband dinner or lunch at the mill. They have lunch. She then goes home, gets things ready for dinner, cleans up, has dinner. And at the dinner table, no kidding, the family looks at her and says, "Mom, you look sick. You need to go to the doctor." She'd been having a heart attack all day long, knocking off heart cells just by the minute. She came in and half the pumping function of her heart is terrible. She needed urgent heart surgery, and she survived, but with a very, very impaired heart. She later gets better, goes through cardiac rehab. By the way, I wanted to plug, when I was listening to Dr. Long's talk about depression, about rehab, you know, there are Mended Hearts is here, and they have an important program for helping people get over heart surgery or kind of reintegrating into it. We got cardiac rehab people here, so it's not like you're alone. Anyway, back to our story. So our patient who spent the whole day having a heart attack and thinking it was the stress of our daily life and lost half her heart muscle, recovers, is at Snowball at a dance, a wedding, and she dies on the dance floor, sudden heart death. They revive her. She comes in and gets an AICD, and she's walking around out there with an AICD, an implantable defibrillator. She's alive, but very, very impaired ability to enjoy life, when what her spirit was about is dancing at weddings and taking care of her family, and not necessarily taking good enough care of herself. This is estrogens, which is an interesting thing and not well known, and that's why I include the slide, that estrogen receptor alpha, and it's funny that it should have the same initials, if you would, as the Equal Rights Amendment. But estrogen receptor alpha may play a role in increasing the QT interval of EKG and increase arrhythmia in the peri-infarct period. And remember when we talked about women having more fatal heart attacks, it may be on a rhythmogenic basis about estrogen. Just an interesting thing. Women in heart surgery, about 30% of all coronary artery bypass graftings are now performed on women. The complication rates are higher in women for a number of reasons. We don't think it's gender bias. There's some specifics about biometrics that are different. I mean, they have smaller blood vessels, recipient blood vessels. They've had more likely to have more important infarcts preoperatively and so forth. But surgery, despite its higher risk, confers equal or greater benefit to women as men. And there's a new interest and more specialty-based emphasis on understanding the effects of heart surgery in women. And this STS is a Society of Thoracic Surgeons, which is a national and actually an international society of heart surgery that's about trying to improve care for men and women alike. Well, I'm not telling most of you anything that you don't know, that women are different. Very, very different. They have similar risk profiles as men. All of these things, men, we're talking about women, but think about this for your wives and your mothers and your sisters and your daughters and yourselves, because these risk factors apply to us as well. The metabolic syndrome is this exploding disease category in America, and it is mostly mediated by obesity. All the component pieces of the metabolic syndrome are made better or ameliorated by losing weight. And you know, the weight thing is an interesting deal. Is if you look at people who are overweight, and I'm one, it's not that we just have extra jeans in our drawers that we're going to fit into, say, next year. It's about and it's not the size of our bodies, it's the metabolic activity of that fat that makes second messengers that cause circulating inflammation and irritate blood vessels. So when your doctor tells you to drop some weight, it doesn't feel very good. I certainly don't like it. Don't like the sound of it. I need to lose weight, and I'm going to do that. Just as soon as my knee gets better and the sun comes out and I can run again. But the impetus is not about how we look in our genes, but how our circulating molecules treat our blood vessels. And so it's a very, very important component of lowering risk. And it's a way that you can sweep about 4 or 5 things off the table if a person achieves and maintains ideal body weight. Metabolic syndrome, here it is. It applies to at least 30% of us sitting in this room and maybe more. It's really, 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 really simple. If your waist is over 35, you probably got it. You probably got it. And then it mediates insulin resistance, it mediates vascular inflammation, it does all sorts of negative things. Ideal body weight is the cheapest, if done right, and one of the most powerful things you can do to improve your health. What are we doing as medicine? What's changed in medicine? Why is it worthy of a talk besides showing some nifty slides? Well, national standard guidelines have changed based on what we now know and will change in the future. So your doctors, all of us graduated medical school 20 years ago or more. Most of us graduated medical school 20 years or more. And every year or every couple of years, something big changes in medicine. And you might have the best doctor in all of Missoula today, but if we don't keep reading and we don't keep changing, we'll soon not be the best. And the same is true for you. What was smart 10 years ago is not smart necessarily today. And there are changes in our recommendations based on more data. The biggest change for most everybody in here is blood pressure. So the ideal body weight hasn't changed, and I'll give you a formula to figure it out for yourselves. For women, 105 pounds for the first 5 feet of height, then 5 pounds per inch for every inch over 5 feet, and for men it's 106 plus 6. So for a woman, if you're 5'2", you ought to weigh 115 pounds. That takes into account, your wrist size, the elbow size, I got big bones, the whole deal. For men, it's the same, 106 plus 6. So I'm 6'1", I ought to weigh 178 pounds. I used to. Obesity, sorry, let me go back one. Blood pressure is the other big change. And it used to be that the threshold for treatment of blood pressure was 140/90, and it's a very political issue, a politically hot topic. It's an expensive thing to change for a national health care policy. It is absolutely true that reductions in blood pressure below 140 systolic or 90 diastolic, reductions in blood pressure result in a reduction in cardiovascular risk, and there doesn't seem to be abasement for it. So when we talk to our patients about what blood pressure they ought to have, it is the lowest safe or tolerable blood pressure that you can achieve appropriately. So 140/90, that seems okay? No. If you got coronary disease, it's very, very important to be very aggressive. And that's new. So if your doctor hasn't told you that, it's only about 3 years old, maybe 4 years now. And it's hard to get blood pressure down. Drop weight, blood pressure comes down. But blood pressure is one of the biggest things that's changed. And the other thing that's changed is the heightened awareness of cholesterol and the lipid risk factors. And those things ought to be reviewed annually, if not more often, with your health care providers. Signs and symptoms of cardiovascular disease in women. The last point is the one I want to make a point of. Any symptom that seems unusual, doesn't make sense, and you think might be your heart is worth understanding. We have patients all the time. I got a patient in the hospital right now who after 60 years of a very successful life came down with panic attacks. Never had a panic attack in her life, wasn't a particularly panicky person. Do you think these are panic attacks? No, they're on my service. They're not panic attacks, I'll tell you that. No, it's coronary disease. So, all of a sudden, well, when did you feel panicky? Well, I had just done the exercise, I had just done this, I felt kind of short of breath, and that made me anxious. And I don't know if anybody's ever felt short of breath, but it gives you anxiousness. It's not a panic attack, but it's a feeling of panic because you can't breathe, and that's what happened to her. So anything that you're suspicious of, that you think ought to be checked out, check it out. The rest of these things we kind of know. And it's interesting, these aren't, the change in sexual functioning is not put up there as a joke, although I could imagine one. Okay, maybe I can think of one. No. That if you look at older women, 70s, 80s, the only thing that's changed is for some reason there's a change in not their sexual drive, but their sexual functioning. That's been an unusual but relatively appropriate guide to look for coronary disease. Interesting. Who should be concerned? Any woman in the room who has 2 of those previous risks. Family member, cigarette smoking, high blood pressure, obesity, metabolic syndrome, diabetes, that list. Family membership is very important in women. If you have a history in your family of heart disease, coronary artery disease in women, that's a very solid predictor that you're at high risk. Any physician, this is a marker to us as well, any physician that does not share your concern should be summarily changed. If you think you have coronary disease and you have those risk factors and the physician blows you off, then you need to make a few decisions in your life. Ask us questions. Remind us to be diligent. Help us to help you do your work to sort through your risk factors. Prevention. No question that aspirin is helpful. It's helpful in a very specific way in different subsets. Clearly in women it's a little bit different than men, but it seems to be most beneficial after the age of 65. Doesn't seem to cause harm except for bleeding in younger women, and for those reasons we advise younger women to have aspirin as well. Interestingly, vitamin E, we see all the time patients come in, I'm on vitamin this, I'm on vitamin that. Vitamin E was studied very rigorously, doesn't seem to prevent heart attacks, but reduces the incidence of fatal myocardial infarction. This thing doesn't work very far. I'm sorry, I tend to walk around, but then I get out of range. Body fat we talked about. And prevention. What do we do? How can we do it? Well, a rule of thumb. You should wear the same size shoes and belt that you did when you graduated high school. This is the last generation that will be able to say that, because there's an explosion of obesity in the primary school system now, so that 30% of high school seniors are overweight, and they should not use their high school belts. But most of us in this room were skinny when we left high school. We should still be skinny today. I know, I just heard someone say that'd be 130 for me. You know, they say, you know, I'd say, well, how'd you feel when you graduated high school? How'd you feel when you graduated high school? Pretty good. Yeah, see? Their ideal body weight charts, most of us should go by the body mass index. It's a complicated way to arrive at it. Not everybody will give you a derived body mass index. The rule of thumb, though, is that 106 plus 6 or 105 plus 5, you'll know where you are. What do you do? Well, begin exercise today. And exercise isn't just help to prevent it, helps to lose weight, but it's actually a very good predictor of whether you got it. So if you look at patients and their risk factors, performance status, exercise tolerance is a risk for ongoing mortality. So a person with very low exercise tolerance has a high mortality going forward, all-cause mortality. It's interesting. So exercise, it may just be a marker, but it may not be causal, but certainly something we had to all be engaged in on a regular basis. What else? When's the best time to plant a tree? 30 years ago. Next best time? Today. When's the best time to stop smoking? Well, never should have started. If anybody in here smokes, stop today. There's new ways to stop smoking. There's a very, very powerful medication called Chantix. It's a nicotine receptor blocker. It works when everything else has failed in many cases. It's worth trying. If you or a family member or somebody you know suffers with nicotine addiction, ask your doctor about Chantix, the new anti-nicotine drug. It works. Aggressive blood pressure management. Very aggressive blood pressure management. If you're on blood pressure medicines now, look at your goals. If you're not on them now but have been bouncing around the borderline, talk to your physician about it. Is it time? There's no such thing as the white coat syndrome. None. The white coat syndrome, everybody hear about it? Has heard about it before? My blood pressure is only high when I go to the doctor. It's high when the guy behind you at Target hits the horn, thought you should have shot the gap. It's high when you get pulled over for speeding. It's high anytime your anxiety levels go up. Reactive blood pressure is what you're talking about. The only reason it's only high in the doctor's office is that's the only place you take it. There's no question that the most powerful medicine that exists in the world today for heart disease is prevention. If you avoid it, if it's too late for you and you have it, but you can help family members avoid it, if we can invest in our schools, invest in our children to avoid cardiovascular disease, then we're way, way, way ahead of this. We can quit having these early morning blood draws. If we invest in ourselves and our communities and understand that most of the risk factors, most of the outcomes for coronary artery disease in our country are avoidable, we can avoid heart disease. If we continue to invest in technology and science and treatments for diseases, we continue to get better as a hospital system or as a medical system. We don't necessarily improve quality of life over what could have been done by prevention. And so while we spend all of our adult professional lives trying to refine our crafts, you can put us out of business. And that'd be a nice thing. Prevention transforms our families and ourselves into healthful, strong, and less vulnerable beings. Thanks.
So I'm going to give you a little bit of an anatomy lesson so that you understand what I'm going to talk about, because it gets a little more technical. So this is the flow of blood through the heart. Blood comes back to the heart through these two structures, which are called the vena cava. It goes into the right heart, and the right heart pumps blood to the lungs. And the most important part about this picture is these four structures here, 1, 2, 3, 4. After the blood goes to the lungs and gets oxygenated and drops off carbon dioxide, it returns to the heart through these four pulmonary veins. And this becomes extremely important in studying the cause of atrial fibrillation in many of these patients. So once it comes back to the heart through those pulmonary veins, these veins on this side all come to the left side of the heart here into that filling chamber, and then the blood is pumped to the body. So what's the big deal about atrial fibrillation? I mean, if many of you know somebody who has atrial fibrillation, you know that it's not life-threatening per se. So what's the big deal? I mean, why not? What's wrong with being in atrial fibrillation? Well, there's nothing wrong necessarily with that actual rhythm. It's a little bit more inefficient for the heart to function. But there is risks associated with being in atrial fibrillation, and there are medical problems associated with being in atrial fibrillation. The most important one is that stroke is significantly increased in patients with atrial fibrillation compared to those who have a normal rhythm. The death rate is increased about twofold from atrial fibrillation, although there's some controversy about whether that's true or not, because there was an important group that tried to prove that you live just as long in atrial fibrillation as you do without atrial fibrillation. But there's a lot of evidence that that's not necessarily true. The medicines that we typically use to treat this problem have a lot of side effects, and the cost is pretty significant. Well, like I told you, it's a common problem. So if you look at, and this is old data. I mean, a lot of this kind of stuff we get data for that ends about 2, 3, 4 years before we end up presenting it. So this is data from about 3, 4 years ago, 6 million worldwide with atrial fibrillation, and the new atrial fibrillation cases somewhere around 350,000 per year. This is what it looks like if you look at the population. This is the general population curve in the United States, and this is where AFib hits. So you can see that it starts at a young age. This is not one of those heart diseases that starts later in life. This is something that starts to affect patients in their 40s, although it is most commonly seen in patients in their 60s, 70s, and 80s. This is just putting some of what I said in a different light. The stroke risk is in many cases 2/3 to 100% increased. So is the mortality risk significantly increased, and the hospital costs are significantly increased to take care of this problem. What do people feel when they go into atrial fibrillation? Most of them get short of breath, or at least most of them complain of some shortness of breath. Palpitations is the other common one because this tends to be a rapid rhythm, so they feel the irregularity of their heart and they feel the heart beating perhaps a little bit stronger. And then we also see on occasion patients who complain of fatigue and chest pain, dizziness, usually if their heart rate is very rapid. Well, a little bit about how this problem is treated. Now, if you look at this slide, I know there's a lot on it, but the next two slides look very busy, but they demonstrate the point very well. If you look at the graph here, this x-axis shows clinical efficacy, which means that the further you go out on this x-axis, the more efficacious the treatment is, the more successful the treatment is for this problem. If you go up to the y-axis here, the market acceptance, the higher you go up on the y-axis, the more there is acceptance by doctors and patients to use that therapy. So if we start at the top, drugs are the least effective, but they're the most accepted because they're easy. When you write a script, you try a drug, it's got side effects, but it's perhaps less risky than some of these other complicated procedures. So drugs are often the first-line treatment for atrial fibrillation, and they're, of course, readily available. But the side effects are one big problem, and the other big problem is that there is a fair amount of drug refractoriness, which means that the drugs initially work and then stop working so well. And so you often see patients who are going in and out of atrial fibrillation, having episodes of atrial fibrillation, maybe since their 40s or their 50s. They've been treated with 2 or 3 different drugs. They always work initially, and then they stop working, and their incidence of atrial fibrillation increases. So if you move down, catheter ablation also is pretty popular because the electrophysiologists, which are the cardiologists that deal with rhythm issues, are able to take care of this in the cath lab, so it's not very invasive. It's a groin puncture, a catheter is moved up into the heart, and an ablation procedure is done. So it's not risky, and it's not very invasive, and so it's very well tolerated. The problem is that the success rate is not very high. And it's a long procedure, and a lot of electrophysiologists shy away from it because it can often be a 6 or 7 hour procedure in the cath lab. Some of these are limited to certain patients. This one has fallen quite out of favor. This is the atrial defibrillator. Now, some of you know about what a defibrillator is. It's implanted like a pacemaker. It is used for life-threatening rhythm problems because if somebody has a life-threatening rhythm problem and passes out, that device can be life-saving for them. The problem with atrial rhythms is that when you go into AFib, most patients don't pass out. I mean, they could be walking on the street and they suddenly get atrial fibrillation. They may feel the shortness of breath or they feel their heart pounding, but they're still upright. And they are aware of what's going on. Well, you can imagine if you suddenly get a shock there, you're not going to be very happy. And if it keeps trying to shock you out of AFib and you're getting these shocks every few minutes, it's very uncomfortable. So patients do not like this therapy at all. There is another therapy whereby we knock out the connection between the filling chamber and the pumping chamber. Then you need a pacemaker. to control your rhythm. But the problem with that is you stay in atrial fibrillation, so you have not necessarily improved the efficiency of the heart. And long-term use of a pacemaker for somebody in their 40s or 50s who gets a pacemaker and needs to have that pacemaker for 40 years is not ideal. So then we get all the way down here to the bottom, which is the maze, and that's where I get interested because the maze is a surgical procedure. It's a surgical procedure that caught everybody's attention in the early 90s when a cardiac surgeon named Dr. Cox developed this procedure, found out in the laboratory how you can create a maze. That's why it's called the maze procedure. As you all know, a maze has one entry into the maze and one exit, and everything else is just blind corridors. The procedure aims at developing those blind corridors so the electricity can go from one entry point only one way, one pathway to the exit, which is down to the filling chamber. It is not 100% successful by any means. In fact, in different people's hands, it's had varying degrees of success. But it has the highest curative rate of any of these procedures. The problem is that it is very invasive because it's done through the front like open heart surgery. It's a long procedure. It initially was fairly risky because the scarring in the heart to create the blind corridors was made by cutting the heart muscle and sewing it back together again to create a scar. Now it's become a lot more simplified and less risky because we use other energy sources to create the scar in the heart muscle so that we don't have to cut it open and sew it back up, which can cause a lot of bleeding. So the procedure has been simplified, but it's still through the front, the full maze procedure. And so there's been a push in the last few years to develop a procedure that is minimally invasive, less invasive, where you don't have to go on the heart-lung machine, where you don't have to have a big cut through the front to try to deal with atrial fibrillation. And that's what I'm going to talk about in a minute. This is that other busy slide I told you about. And the reason I like this slide is it shows you that we still don't know how to deal with atrial fibrillation. And everybody deals with it differently. So you go to 10 doctors and you'll get 10 different strategies for atrial fibrillation because there isn't really a good standard. And so you run around this cycle in different directions, going back and forth. You might see a different doctor if you get upset, but you'll change drugs. You might get an electrical cardioversion. That may work for a while. You'll use drugs that include a blood thinner. You might consider a catheter ablation, or you might consider a device. If you see a different doctor, he may not go that route. He may go that route and recommend surgery or a device. So it's confusing to me. It's got to be confusing to you too. But that's where we're at because nothing works perfectly. If you had a perfect therapy for this problem, that's what everybody would get. Well, let me tell you a little bit more about the anatomy before I show you the procedure. The patients, if we catch them early enough, atrial fibrillation is a continuum. For a lot of you that have valve disease, it's a continuum that proceeds fairly rapidly, and sometimes you go into atrial fibrillation and you stay in atrial fibrillation. You never come out until we intervene somehow. For those patients who have atrial fibrillation that's not associated with valve disease, for example, that just the only problem they have is their atrial fibrillation, it's usually a continuum where it starts with infrequent episodes that are easier to get patients out of. But over time, they get more frequent, and then it becomes continuous. We think that for most of those patients, the problem is right here in the back of the heart where those 4 pulmonary veins come from the lung into the heart. The junction on the inside here between these veins and the heart muscle itself, that junction is where abnormal excitable cells from the vein side trigger the atrial fibrillation on the heart side. So if we can create a scar right here around these pulmonary veins such that whatever's happening right here can't excite the heart muscle because it hits the scar and can't go any further, that would be an effective therapy. And that's actually what the catheter ablation, what I was telling you about coming up through the groin, the usual catheter way, that's what it aims to do. It aims to try to create scar around all four of these openings. The problem is that from the inside, it's not very well seen, and if the circular catheter device is off a little bit, the scar might create block, say 3/4 of the way around, but on the last quarter where it wasn't lined up properly, there's still excitable input to the heart. So that's one of the reasons why the procedure fails fairly frequently. So what we think we need to do, though, for these patients, number one, is to create an absolute guaranteed scar around the outside of these veins, just on the cuff of the heart here, so that anything excitable out here doesn't get into the heart. The other thing, that's part one, because the new procedure has 3 parts. And this is just to show you that there is some evidence for that. When the problem was studied in terms of triggers for the atrial fibrillation, this is just a schematic, but in trying to study where these excitable cells were, you can see that most of them are around the openings of those 4 pulmonary veins. There's a few here on the right side between the vena cava. Remember, those were the veins that bring blood back to the heart on the right side. So there are a few other foci, other areas of excitability. And that triggered people to look for why that might be, and that led to an investigation of the nervous system. This is a drawing of the parasympathetic nervous system, and I draw it to show you that a lot of these heavy parasympathetic nerves, our nervous system is divided up into the sympathetic and the parasympathetic, but a lot of these parasympathetic nerves that run down to deal with the stomach and stimulate the stomach run right by the heart. And it turns out that there are little nerve centers. If you can see here, there are the 4 pulmonary veins right here. And it's not depicted very well because it's right along the edge where the pulmonary veins enter the heart is where you find these little nerve centers. But they're called ganglia, and these ganglia run along the junction between the pulmonary veins and the heart. And it looks something like this in a schematic. These are little nerve bundles called ganglia, and I'm just showing you the right side. The same thing is on the left side. But there are a bunch of them, and what was discovered and is now called the dysautonomia hypothesis is that if you inject certain proteins, neurotransmitters, the proteins that stimulate these little nerve centers and that come down along those fibers that I showed you in the previous picture, if you stimulate those nerve centers, it was first done in dogs, but if you stimulate those nerve centers, the dogs go into atrial fibrillation very frequently. So it led to the dysautonomia hypothesis, which has been shown in humans as well, which is that if there is hyperexcitability at these little nerve centers, you can stimulate atrial fibrillation. And the fascinating thing about that, to me, is when you get one of these patients that tells you, I go into atrial fibrillation every time I eat a big meal, and I get absolutely full. And what's interesting about that is that supports this theory that when the stomach distends and gets really full, and there is more parasympathetic nerve stimulation down to the stomach, those nerves are sending off branches to these little nerve centers, these bundles, and hyperstimulating them as well, and that's causing atrial fibrillation. So all of this study led to trying to deal with this in and out atrial fibrillation called paroxysmal atrial fibrillation in a slightly different way so that patients would not have to go through a bigger surgery. Wouldn't have to go on the heart-lung machine, wouldn't have to have their chest open through the front. And this is the result. And so right now, it is focused on patients who have at least tried drug treatment and it hasn't worked, or it worked initially. Remember, I was telling you, some of them it works initially and then it starts to fail and they get more of these episodes again. And or they have symptoms with it, which in young patients that are active, and that's what we're seeing a lot of, is patients who are more active who notice that they are limited when they go into atrial fibrillation. So it's targeted for those patients, at least right now. Like I said, it's done off of the heart-lung machine. We use a combination of direct visualization through a small incision, which I'll show you in a second, and a camera to help see. The energy source, remember I told you, it used to be cut and sew. Now we're using different energy sources. There's all kinds of different energy sources that have been studied. Some have fallen away and some have survived. The laser, for example, has failed. Microwave is still being used. Cold temperature, cryoablation, meaning to drop the temperature of the heart muscle in that one area where you want to create a scar to very, very cold temperatures will cause a scar. And then radio frequency, high frequency energy delivered to create a very thin burn line is what we're using for this procedure. And the last part, because remember I told you about the two parts, we isolate the pulmonary veins and we take out those nerve centers that end up being positive when we test for them. The last part is to take off the atrial appendage. And I'll show you a picture of that in a second, why that's important. This is how it looks from the outside. There's one small incision. It's about 2 inches or 2.5 inches long, and 2 small port sites. So that's done on each side to be able to get to the right-sided pulmonary veins and then again to the left side. On the left side, we take off this little atrial appendage. The next picture will show you why it's important to take that off. This just demonstrates that that's the third part of the operation. This is what reduces greatly the risk of stroke for patients who have atrial fibrillation, because most of stroke happens due to blood clots forming inside this little stump. And you can do without it. And so we're able to take it off with a special stapler so that it's gone and there's just a line there flush with the heart muscle so that there's no chance of forming blood clot in there. Now, if you look at this picture, you say, well, why would you form blood clot in there? I mean, the blood's just going to swoosh around. If this thing was still attached, the blood would just swoosh around like this and come right out, and why should blood clot form in there? The first thing you need to know is that when the heart is contracting, the blood is washing in and out of that blind pouch. But when in atrial fibrillation, when the heart is fibrillating like this, the blood is static in there. It's not moving. And that's when blood clots can form. Well, the reason why blood clots can form is that not all atrial appendages look like that. They look like this very often. And the problem with this is that the blood that gets in here is not going to be very well washed out if you have this little blind pouch. So there are all kinds of different variations in how the atrial appendage looks like, but these are the ones that are concerning. If this patient, for example, had an atrial appendage that stopped right here, probably their risk of stroke would be lower. This is what the incisions look like. So you can see they're small. This is the right side, this is the left side, and there are just 2 small port access holes and a small incision. And that's how we get it done. The success rate with the procedure is somewhere around 90%. Now, having said that, there are results that I've seen that are better than that. There are results that are worse than that. But in the end, the results end up being at least close to 90% for certain patients. There are some surgeons who are trying to do this procedure for patients who are always in atrial fibrillation, but the results go down then, down to about 50 or 60%. So right now, we're picking patients particularly who go in and out of atrial fibrillation or who are in atrial fibrillation all the time, but only for a short period, like the last few months. And we'll see where it goes. We've done I think 7 so far. We used to do this through the front, so it's not that foreign to us in terms of how to get this procedure done. The only difference is that we were doing it for patients who needed valve surgery or bypass surgery as well. We do this procedure at the same time. Now we offer the procedure on its own through these small incisions, and hopefully this will make a difference for a lot of people. The patients that I see more commonly, I just saw a 39-year-old lady a couple of weeks ago, but more typically they're patients in their 40s, 50s, and 60s who are still fairly active, and this bugs them. It bugs them to go into atrial fibrillation. The first patient I did was a basketball coach from Plains who was fed up with not being able to keep up. He was very athletic, very fit, and fed up with going into atrial fibrillation and not keeping up with his students. And so this turned out to be very good for him. So that's it.